welcome to the Massage Science Podcast. My name is Eric Purvis. I'm a course creator, educator, researcher, RMT, and advocate for evidence-based care. My apologies for the large gap between these last two episodes. Life happens and other priorities pulled me away. And then I was away overseas for a much-needed vacation. But I'm happy to be back and hopefully can share a few more episodes in the next few weeks. Today is the final episode of my 7-episode series with Monica Noy. In this episode, we have a discussion about making a musculoskeletal pain assessment. This episode should help to put some of the pieces together about how to integrate the information from this series into something that is clinically useful. As always, thank you for being here, and I hope you enjoy this episode. Here we are, episode 7 with the most amazing Monica Noy. I've really enjoyed making these. Monica says she's enjoyed having these conversations too, and we hope that all you listeners out there are enjoying these and getting something valuable from them. I've dropped a few hints to some people that I've spoken to recently about this, and they're so excited. And this one here today is going to be our final module discussion, and this is going to be on making a musculoskeletal pain assessment. All about putting this information together into something we can use in the clinic.
Yes. And this again is not caveat, is not mine. I with permission stole this from John Quinner, who put this together. And then I've certainly added to it since to clarify my own understanding of things and just to present it to various different audiences and create a little bit of a tool that we might be able to use. I'm sure there are probably more creative people out there who could make it better. Hopefully in the future that will happen. Yeah.
It's such a great idea because we learn how to assess joints and muscles and conditions where pain is, I would say, almost always the primary concern or complaint.
Yeah, it's a very, very high percentage. Yeah.
Yeah, but we don't ever actually learn how to make a pain assessment.
Yeah. And it turns out I don't want to say different types of pain, but there are certainly different presentations. And there are some presentations where people present with something that doesn't necessarily make sense to us as clinicians, but it tells you that there are mechanisms going on that will change how it is that we clinically reason for our treatment. We're used to the really mechanical kind of stuff where it's joint related or muscle related. And we can more easily reason things out, although we might get into the trigger point on this one. So
let's do it.
Especially for massage therapists. That's always been a fun one for me. So it just enables us to be able to say, based on what this person is coming to me with, I can understand some of the hypothetical mechanisms that may be occurring and what that might mean or how I address this person with treatment. Yeah. So that's where we're going. So that's what that deck is. Yeah, that's what that deck is.
Well, let's begin. Just you go ahead. Just tell us a little bit more about maybe some of the preamble stuff that sits before making a diagnosis or before making an assessment. Sorry, I think that's the key thing. Is it's assessment versus diagnosis, not the same thing.
Yes. Yeah, we're not making a diagnosis in a medical sense because it's not something that we are really allowed to do. So it's really assessment and impression for our own benefit, not necessarily for us to quote unquote explain that person's pain to them. Although some of the neurological information can be useful to people depending on who they are and what they like. But again, usually I try and contextualize things. If I haven't already done it, I'll certainly contextualize this making a pain assessment within the operational paradigm that we exist within, which is biomedicine. And a lot of allied health professions, or what might be called alternative as well, health professions, some people will call it alternative or complementary, depending on where they're coming from. But a lot of the time, we don't realize that we actually are educated within a biomedical construct and a biomedical paradigm. So we use these biomedical constructs all the time. We use anatomy, physiology, neurology, pathology, all of those kinds of informations. They don't come from our professions. They come from a biomedical perspective, and we draw on them for our purposes. So we're not in any way, this is our foundation. And I think that it becomes challenging because people often criticize biomedicine and often criticize the paradigm in which we not only exist, but are educated, and want to distance themselves from that. And oftentimes people use straw men to do this. It's like biomedicine bad for these one or two reasons. And then this alternative or this complementary or this other way of doing things is better, which isn't really the case. But
would you say, sorry, Monica, just interrupt for a second.
No, go.
Would you say, though, that so people say biomedicine is bad, this other way, this complementary, not biomedicine way is better. But would you say that the philosophy, though, that the complementary ones are doing is still very biomedically based?
Yeah, 100%. Everything we do is biomedically based because we're using biomedical sciences in order to construct whatever, we'll get into this in a second, but whatever kind of thought processes we have about that. The problem being that I'm just going to get to this paper, which I present. This is actually a good paper. It's an osteopathic paper, but it's not related to only osteo. It's called The Fallacy of Osteopathic Anatomical Possibilism. Actually, it's not called that, but that's what it's about. So it's all connected, so it all matters. And the fallacy of osteopathic anatomical possibilism. So we take this biomedicine, we take all of the sciences, and then we manipulate them through a different perspective, through a massage therapy or an osteopathic or a chiropractic or a physiotherapy perspective that is sometimes deficit of some of the sciences that are out there, but also has this problem where we impose relationships on structures or on systems or on relationships between what we do and how a person reacts or how their systems react or whatever it might be. And because we're thinking, well, I did this and this happened, so let me fill in the gaps as to mechanistically how this happened. And that is often based on a perspective that is about it's possible, I guess, because it's all connected. And then we can basically say anything we want to. We can construct these elaborate mechanistic possibilities. So that can often happen within our professions. And that's one of the reasons I try and contextualize this, where it's like we come from biomedicine. So it's like there's all this idea that we may have to pay attention to other kinds of traditions, but for some reason we try and distance ourselves from biomedicine. And that is one of the founding traditions of our professions. So
this is such a great paper, and I read it last year when it first came out. So admittedly right now it's been over a year since I read it, but it hit on so many key points that are a problem in our manual therapy MSK world.
Yeah.
Because the one quote that here it says it's the imagined, exaggerated, or implausible relationships claimed to exist between anatomical structures. And this is such a thing that we see I can only speak from a massage therapy perspective, but I'm sure I'm not alone because osteopaths are doing it too. And I'm sure chiros and physios are.
Oh, 100%.
Is we make these clinical impressions or a diagnosis based on this very convoluted, the toe bone's connected to the ankle bone, connected to the knee bone, connected to the hip bone reasoning process.
Yeah.
That is impossible. Because you could say anything's connected to anything.
Exactly. Which does end up happening.
Exactly. And it gets, if we're going back to making an assessment or into trying to better understand pain or some of the causal stuff we've hit on in most of these episodes, there's no end.
No, there may be no end. Yeah,
Yeah.
absolutely. And that makes it it's good for the profession that you're in, because you're able to have explanations for things that go on and sound perhaps confident about those, or reasoned about those kinds of things. It's, oh, this didn't work. That's because this issue is here, or this, and I have to deal with this first, or I have to deal with that first, or some other kind of thing that's going on. And it misses where connections might actually be reasonable. And in a pain situation, and I'm going to use me as an example, because I've talked about my ankle, which I did a number on. And it's healing. I think I haven't had a scan because therapists are the worst patients. So I haven't actually gone to have anything looked at. I can wait there, it's healing. But where it was very much contained to the ankle at a certain point, I'm pretty sure probably torn a ligament, definite tissue damage, swelling, all of that kind of thing, very specific acute related pain, which makes sense. As the healing process has gone on, and this happens, is that the whole limb starts to become what Asavas called a nociceptive, like a nociceptive origin, basically. And that relates to how the nerves might change in sensitivity related to the injury, which is described in the paper that was dropped recently, which was the adhere to the aphorism paper that he just dropped, which relates to a functional capacity that might be inherently advantageous on an evolutionary level. But basically what I have is a sore, tender ankle, but my whole leg hurts, right? To some degree or another. There's sensitivity there. My whole foot is sensitive. And that kind of relates to what we understand happens when there's tissue damage in relation to the injury. So that's connected. That's connected in a very reasonable, explainable, physiological way. So then if we make up these other possibilities for connection, we miss the ones that do exist and how they may impact what it is that we do on a treatment basis.
Stay with us. We'll be right back.
I am excited to announce that the Massage Science Podcast and my company, the Center for Evidence-Based Education, are now official partners with Noterro. Trusted by thousands of healthcare professionals, Noterro has been dedicated to serving the massage therapy and healthcare community for over 12 years. Noterro makes clinic management easy with scheduling, billing, and charting in one place. Whether you work in a clinic, from home, or you have a mobile practice, everything you need is right here. The new Noterro Go is tailored for mobile practitioners, streamlining workflows and helping you to run your business more efficiently. Visit noterro.com/CEBE to start your extended 44-day free trial. That is noterro.com/CEBE. That's such a key thing that I'm glad you brought that up. And it's something that I try to, in my courses, I try to address as well, is that everything that we see clinically, everything that somebody experiences as a patient, things like you said, where there's been tissue damage, but the whole leg becomes a nociceptive
I know
environment.
I'm trying to think of the word.
A nociceptive canister.
Yeah. It's like a cause, basically.
Yeah. We can explain or understand what's happening with the person based on physiology or neurophysiology, or those nociceptive processes.
If we know to be able to do that.
If we know. But we can always, it's a more right or a less wrong approach. I think it's a more right approach than trying to connect these fascial lines or these joint loading things, which Is there relevance for those things? I don't know anymore.
But we're going to see. So if I look at myself in a mirror, I will see a weight bearing shift. I will see that my foot is externally rotated. I'll see, and I'll be able to match that with the tension that I'm feeling in my glute. A therapist might see that my iliacs don't necessarily align, that my thorax perhaps is somewhat rotated because I'm compensating for whatever weight bearing shift because of this issue with my ankle. So we will see these things as therapists when someone has this kind of an injury. But what we do is not think about those as reasonable ways in which someone might actually deal with an injury or pain and the growing sensitivity or a nociceptive area, but we will see them as causal for the pain that person's having. Oh, you're not weight bearing because your hips are out of alignment or because your thorax is rotated or because whatever it might be. And so we flip it to be causal rather than actually consequential, and reasonably so.
I like that word, consequential.
Yeah.
The things that
And
we see, those traditional kind of musculoskeletal structural changes that you see are because they're consequential to the fact that you injured your ankle and you have this nociceptive environment in your leg.
Yeah. Yeah. And then you're dealing with it in various different ways. Now, does that mean you won't hurt somewhere else? No, it might even mean that as a therapist, when you see these things that you've been trained to see, where there's maybe some postural changes, there's weight bearing changes, there's something that you see is uneven, it doesn't mean that you treating what you feel as tension or muscle tension in a certain area related to that isn't helpful, because it could very well be helpful for the person to not feel that tension, even though it might build back up again because they're still dealing with it. But it may be helpful for them to not feel it if it's causing discomfort or various other reasons. It may, who knows, help them weight bear better on this injured ankle as part of recovery. It's hard to know. We can't necessarily make these one-on-one correlations. But the important point is to not make them causal, because that's where the anatomical possibilism comes in, where we see these things and we're like, I can explain why you're having this pain. So now, hold on, I started with this pain. Maybe you can explain how that changed something about what I'm feeling.
Yeah. And this just goes back to that knowledge gap, which we've been saying every episode and started with, was that huge knowledge gap, is that because there might not be that pain education or the pain knowledge to help explain things, we come up with other stories, other rationale to try to explain what we see and feel and what the person experiences, because people are trying to fill in that gap. And unfortunately, the gap has traditionally been filled in with 100-year-old belief-based ideals.
Yeah. And observational things as well, where we can this happened, therefore this must be the reason it happened. And and then they become law, and then they become something that we start to extrapolate to everybody. And that becomes quite problematic as well. And I used to think it was because we just were missing some sciences. So maybe if we had more neuroscience or neurophysiology, then we would be able to connect the dots. But it goes way beyond that with regard to pain education, because it's such a conflated field already. And we're starting to see much more information coming from neuroscience related to nociception and pain, but that has to infiltrate through. The goal that we might have, instead of actually being able to say, oh, we are pain experts or we're pain therapists or whatever it might be, is that while we're getting our ducks in a row with all of this information, that we can at least limit the misinformation.
Yes.
That might be the biggest thing that we can do, is to not make these massive assumptions.
The idea that neurophysiology, neuroscience education would make a difference is something that I thought for a while too. And I remember having conversations with people early days into looking at this information and talking about, let's say you want to talk about trigger points. We talk about it now, we're going to talk about it later if you want. It's up to you. I'll leave you in charge of the trigger point thing. But I remember somebody being like, oh, we learned all this neurophysiology or all the neuroscience I needed in school. And they've been practicing for 40 years and they thought that was enough. And that explained all the things they need to know about pain or trigger points and stuff. And I think that is a closed-minded way of thinking because it's incomplete. You need to know the neuroscience. I think it helps to know like synapses and receptors and receptor types and different fibers and how things work in the spinal cord through the dorsal root ganglion and interneurons and blah, blah, blah. You get all that. I think that's important, but the context of it needs to be, how is this relevant to pain?
Yeah. And not only that, but if we're going to go for trigger points, trigger points are indicative of a problem that exists related to anatomical possibilism, where there's a piece of information that's come out. It uses forms of anatomy and science, basic science. It provides a perspective that gets taken up and becomes accepted knowledge. And this happens not just with trigger points. This happens with a lot of other kinds of things. The paper that just dropped, due to an aphorism, why nociception is necessary for pain, it describes the same sort of thing, but with relation to the idea that nociception is neither necessary nor sufficient for pain, which was the aphorism that they are analyzing. But that sort of came out. There was certainly some science behind what was presented, like a lot of neuroscience actually behind what was presented, but it was provided through a particular perspective, and this became accepted knowledge that people are now like, yeah, no, we can have pain without some sort of neurological component, which on a science level isn't supported. But the trigger point, that was an example of that, where it became just accepted. So part of it is not just that we didn't necessarily have the pain knowledge that we needed, but part of it was also there was a refusal to address the critiques that became evident in the description of the trigger point. It was basically a testable hypothesis that when tested didn't really stand up. Like parts of it did. There were parts that could be kept and shifted to a different question. And then we could look at that question and study that. But it's just accepted as given. And that becomes a real problem. So, yeah, go ahead.
Sorry, just to clarify here. The thing with the trigger points, this is from what I understand, is that it's a clinical phenomena. We all have experienced feeling the traditional air quotes trigger point. People you push on it, and you as a therapist, maybe you feel something there, maybe you don't, but the patient feels something and you get that traditional referral. So there is a clinical reality to it.
That is phenomenon. Yeah.
Clinical phenomenon. Okay.
Yeah.
And so I understand that too. And that's the way I think about it. But from what's happening in the body from a physiological, anatomical phenomena, it's not what that traditional Travell belief was.
No. And it also, trigger points have been really problematic in a lot of ways because they led to this myofascial pain syndrome and some circular reasoning related to pain. But you're talking about when someone comes in with a sore spot in the muscle that has some of those characteristics, you're talking about someone who's reporting pain to you. And this is where the pain assessment comes in. And it's done by looking at various like contextualizing it, but also having a much better understanding of the clinical descriptors that are related to the mechanisms or the hypothesis of mechanism. And these are nociceptive, prosoplastic, and neuropathic. And so they have different kind of descriptions related to them so that we can start to understand what might be related to normal functioning of the nociceptive apparatus and abnormal functioning, and then functioning related specifically to the nerves itself, to a lesion or disease of the nervous system. So getting to know those things, which is part of what the course does, is contextualize some of those. But getting to know those clinical descriptors, it allows us to start to distinguish. And this is not new. Like John didn't come up with this on his own. There's a table from Wolf from 2009 that has similar setup. And there are other papers along the way that have categorized these things as well. Nociplastic, a little bit newer. Obviously, that's not in the Wolf table because that's a new one. They've also added like to nociceptive inflammatory just to consider what else might be going on in terms of when someone might have inflammation with relation to tissue damage. So all of these things become quite helpful for us. And then we can see where these things might be associated on different musculoskeletal levels. So what we might be dealing with most of the time on a musculoskeletal level, if it's non-problematic, we might more categorize as nociceptive. Hypothesis of mechanism, meaning we've got a normal functioning nociceptive apparatus in the area, and there might be inflammation because if there's tissue damage or something along those lines. And then there's neuropathic, which is related specifically to a disease or lesion of the nervous system. We don't need a diagnosis that there is one present. We should be able to actually have some indication that there may be one present based on the nerve symptoms that are present. And then nociplastic, which is the newer one and has actually become a little bit of a problem because it keeps getting conflated with a whole bunch of different things. But it's just another way of describing a mechanism which is altered. It's an altered nociceptive mechanism. So it's not the same as nociceptive. It's there functioning in a capacity where you have particular symptoms that will indicate to you that processing of information has been altered in some way. And that's usually allodynia and hyperalgesia or other kinds of forms of sensitivity.
One thing, Monica, just to clarify, just for listeners, also for myself, is so nociceptive is probably the thing we see most likely in the clinic. It's kind of what you're saying. And would that be, because I've seen some people conflate the two as nociceptive being more mechanical. Would that be a fair kind of comparison?
Yeah, I think we could definitely correlate that in a way, because what we see is what we would describe as mechanical. So the descriptor for mechanical in various different places, but it's basically, you'll see mechanical pain, which doesn't really make sense, but it may be nociception that's induced from mechanical nociceptors based on movement, right? Movement relationship. So we start to see there are particular characteristics to that pain is usually reproduced with load or stress on the joint or something like that. It's often associated with specific movements or specific positions, but it's not constant. So in a change of movement or position, it'll change unless there's an acute injury. It's a different thing.
I have a
It's generally localized, right?
Yeah, it's localized. As I sit here doing this, it doesn't bug me. But if I bent over to pick up something from the floor, I can do it, but it's uncomfortable, and I'm going to change how I move to try to avoid it.
Yeah.
Why that? I felt something twinge my back a little bit yesterday when I was at the gym.
Yeah.
I've been in the gym in a week. Did I try to do too much? I don't know.
Strain something.
I did something. I upset tissue in mechanical. And so I would view that, and I would explain that. If it was a patient, I would say, I would say it's nociceptive, because I probably don't have no idea what that means, but I would think it's nociceptive nature. Something's irritating.
It's normal.
It's normal.
You're not having any nerve referral into the feet. Nothing. It's not sensitive in some way. It's very much related to movement. So we start to see those characteristics,
Yeah.
and it gives us a little bit of an understanding of that they're not falling into this category or that category. So we can be more safe in the assumption that things are functioning as they should within this relationship. Now, there might be different reasons that's occurring, and that's a whole other level of assessment that we normally do anyway. Whether or not we might be thinking, oh, they might have a disc issue for these reasons, or because there's an X-ray, or there's degeneration that can be seen. So it's like we can start to think of other contributing factors that might be there, or as you said, overuse or something along those lines. So we'd have to tick off a level of those boxes anyway. And so we'd be looking at all those things. But yeah, so we would correlate those. We would categorize those in particular ways.
I think that's the thing that we're looking for, that you're talking about these things, is that there's your correlations or associations, but they're not causal. So you'd see this, and that would be correlated with.
Yeah, like there's a definite relationship between what we might categorize as nociceptive and what we might see on a clinical picture as being really associated with these particular elements.
One thing I wanted to ask you about nociplastic pain, just for clarification.
Yeah.
My understanding of nociplastic pain is it's just in the periphery. It's only stuff that happens outside the spinal cord.
So
is that correct?
This may be where there's some challenge there. So it's pain that arises, the definition is pain that arises from altered nociception, despite no clear evidence of actual or threatened tissue damage causing the activation of peripheral nociceptors, or evidence for disease or lesion of the somatosensory system causing pain. So the idea, I'm just going to go back up to this, the idea of nociceptive is due to the activation of nociceptors, and we generally tend to relate that to a peripheral aspect. And I was looking at the definitions. And I use this as an explanation, but there's nothing in the definitions that specifically ties nociception or nociceptors to the periphery.
So even though it says for nociplastic causing the activation of peripheral nociceptors, there could be central mechanisms.
That's saying there's no evidence there. No. So we're seeing this particular activation, but what we're not seeing is evidence of peripheral nociceptor activation.
Okay.
So it's not saying that it's only peripheral nociceptive activation, is my understanding. And give me 1 second because I'm going to up to the ISP terminology, because I kept going back and forwards to this and I can never quite understand. I can never not understand, but I can't be keeping things in my head. Actually, I've got all the definitions on my deck, but this is easier. Because nociception is the neural process of encoding noxious stimuli, and then nociceptor. Okay, this is where it does go to the periphery. That's my error. I might have to review what I wrote. So nociceptor is the high threshold sensory receptor of the peripheral somatosensory nervous system that's capable of transducing and encoding noxious stimuli. So the nociceptor, when we talk about nociceptive hypothesis of mechanism, that's where we associate that with the periphery, right? With peripheral nociceptors.
Yes.
And activation of those nociceptors that are in the periphery. However, the clinical descriptor for nociplastic is that it's arising from altered nociception, and nociception is not periphery, right? It's related. So nociception is the neural process of encoding noxious stimuli, and encoding can occur in both the periphery and the central nociceptive neurons. So that's not related specifically to periphery. It's just that when you see this altered nociception or evidence of altered nociception, we don't see evidence of peripheral activation. It's basically a rule out. It's basically a way of saying We don't see evidence of a disease or lesion of the nervous system. We don't see evidence of what we would otherwise classify as a nociceptive mechanism. So what we're left with is evidence that tells us that there's an alteration in that nociceptive process.
And we're not sure where that's coming from.
And we're not sure where that's coming from.
Yeah.
But it's not specific to peripheral. It's just saying
no
we don't
activation of the peripheral.
We don't see activation of peripheral.
And I think
not that there isn't, just that we don't have evidence of it.
I think that's a confusing definition, because I've had this conversation with a few other people over the years, and I've listened to other people talk about it, and there's a lot. It's confusing. There needs to be something. I don't know what it is. I don't have a suggestion right now, but I do know from just, I'm trying to understand what the heck nociplastic is unclear. And I think it's because the definition is itself unclear.
Yeah. And there's been a few papers written on it, and some of those unfortunately conflate it. Others are trying to give a better explanation of it. And this was my understanding for reading some of those papers. And also because I came across the same thing where I was confused, and other people had come across. I was in one pain forum where they basically said it's specifically peripheral and all that sort of stuff. And then at the same time conflated it with central sensitization. Anyway, it was, and I was like, okay, everything is a bit weird. But from what I can understand and just being able to articulate it this way is that the nociception is altered. It is not nociceptive in the way that we would understand that as related to activation of peripheral nociceptors in what we associate with that mechanical understanding or perhaps inflammatory understanding. And so the system is altered, and we don't have evidence of activation of peripheral nociception. Not that isn't. we don't have evidence of neuropathic mechanism. So, does that make sense?
I get it. Yeah, I understand. Yeah, I just wanted just some clarity on that, because I've seen the same thing that you were saying, is that I've seen the common description or common discussion around it is it's just peripheral nociceptors.
Yeah, that's the common discussion.
And then so there's something happening in those peripheral nociceptors only is the way I've heard. And I've seen other people talk about it. And I think you said they conflate it with central sensitization. I've seen that too, where nociplastic pain is a peripheral
weirdness.
Yeah, I think peripheral demonstration, peripheral weirdness from central changes. And that one didn't seem right to me either. But it's
So there could be activation of peripheral nociceptors.
And there could be activation of central nociceptors.
And so it's not limited. It's basically looking at nociception on an apparatus level. It's just distinguishing it from the other clinical descriptors that we have, which is nociceptive and neuropathic. And nociceptive being, what we talked about, and then neuropathic being a lesion or disease of the nervous system.
So if it's not one of those things and the person has pain.
And the person has pain with specific evidence of sensitivity, which is that allodynia and hyperalgesia, and there can be other levels of sensitivity as well. But yeah, those are, and so that would be the sort of characteristic of that as being a mechanism. So within a central sensitization, as it's currently defined, nociplastic would be a possible mechanism within that particular issue, right? It's not the issue. It is one of the mechanisms that would exist probably within a centrally sensitized state. There would be an alteration of nociception. Yeah, it's interesting, actually. It is. It's a lot. And it helps to really talk about it and clarify it. And I will, the next time someone asks me that, I'll have to sit and think about it for a while before I can clarify it like that. And hopefully when Anissa, John, or Asaf listen to this and I got this wrong, that they will clarify that for me. But I think from my understanding, it's the closest I can get to there. But when we look at something in that making a pain assessment, so some of the examples that are given would be if there was an impairment of the apparatus that led to altered nociception, which is the nociplastic. Examples of that might be an impairment that would have this particular mechanism would be chronic low back pain without any other kind of explanatory findings. So it's like someone has this sort of sensitivity. There's maybe some tenderness in the area, some low back pain, but there's nothing that would otherwise explain the symptoms and the sensitivity. Complex regional pain syndrome falls under that. Nociplastic is not explanatory it's not the same as the label of chronic regional pain syndrome. It is a mechanism that would be evident within that particular condition because it presents having allodynia and hyperalgesia and other forms of sensitivity. And the person who may have an illness label, right? Fibromyalgia, IBS, myofascial pain syndrome, various other things like that, where you would have evidence that there is a nociplastic mechanism in relation to that particular issue. Again, not the whole issue. It's a mechanism within that issue. So one of the other things with nociplastic impairment that I have in this is that you have a recurrent sore spot on the body. That would be a local impairment, a local nociplastic impairment. So a local alteration of nociception.
So you're saying if you have an ongoing sore spot, they're like, oh, that's my spot. People.
Yeah. When you press on it, there's referral.
Yeah.
You have those considerations.
Yeah. That would be characteristic of a nociplastic, a localized nociplastic.
Yeah. So if we do a pain assessment, and I don't want to spoil it for everyone, but it is a fun one to look at and people forget. So we have this phenomena. We have a sore spot on the body, could be reported as spontaneous. It could be in response to pressure, palpation, when people carry a purse or something and just, oh my God, it really hurts. It could be anywhere in the body where there's muscle. No known mechanism of injury necessarily, right? These things might certainly be correlated with states of tension and various other things. There could be a referral pattern when you press on it. And you could have a referral down the arm, you could have a referral up, which if we look at those referral patterns, they're usually following nerve pathway, right? They makes anatomical nerve pathway sense. Possible torque band that may or may not be palpable, right? People often feel that there's some sort of tightness within the muscle, like some sort of band of tightness. And there could be a possible twitch response with regard to palpation. So something that happens in that muscle, that twitch response. So in terms of a pain assessment, what we're looking at are Okay, so we got phenomena. And then if we go to characteristics of this trigger point, when we're trying to make a pain assessment, we're then going to look at how we can characterize what this means and what sort of mechanisms might be at play. So if we've got this sore spot on the body where we have this, anywhere there's muscle, etc., it can be both spontaneous, okay, so without stimulus, or stimulus-induced reports of pain as well. So we have two. So it's not one thing or the other. It can be possibly both. There's likely that people have pain at rest. The aggravating factors can be various, as well as the relieving factors. And the aggravating factors and the relieving factors may be the same at any given time. So it's like in one day it might be relieving to apply heat. The next day it may actually be aggravating. It can include movement. Movement might be aggravating or it might be relieving. Sustained positions or inactivity might be aggravating, might be relieving. Rest, pressure, all of those kinds of things. Pressure can be relieving, could be aggravating. So those things don't necessarily pattern, right? They're not consistent. And then it can be a localized spot with a referral pattern as well. So you press on it, you get this referral. It's irrelevant. The time of day is irrelevant. This can occur at any time, or these elements can occur at any time of day. You might wake up with it, you might not. It could happen during the day, it might not. There's some characteristic descriptions that are actually more neuropathic. So there's stiffness, hot, burning, dull, aching, right? Kinds of descriptions of pain. You can have others as well, along with sharp, and you can also have movement associated. And then the intensity is variable. It might linger after the stimulus is removed. And it can vary depending on the stimulus. So it might be that for some people, a small amount of pressure will cause a response or a report where that's a large amount of pain. So once you start to look into that, you start to get the understanding that there may be various mechanisms, and there may be evidence of allodynia hyperalgesia in relation to that sore spot. So there's some form of alteration or sensitivity in that mechanism.
And all the stuff you described sounds very similar to trigger point ideals.
Yeah, but also you can match some of that with someone who has fibromyalgia.
Yeah.
Or someone has myofascial pain syndrome, which is what the trigger point is supposed to be like causal of.
Yeah.
Now you've got a bunch of mechanisms that are possibly in relation, a bunch of neurological mechanisms related to pain that are existing.
And that that they exist, and understanding them helps to explain the patient experience as well as the clinical experience of what we see and feel and what the person sees and feels.
And it also helps to explain why treatments apparently are incredibly varied in terms of what they do, but also not necessarily very helpful.
Yeah.
Do we get rid of trigger points? Like certainly in some cases, or what we would classify as trigger points. Certainly in some cases, people can be treated and they may never experience that again. But what we see in terms of why the trigger point was associated with myofascial pain syndrome is that these are recurrent, that these don't go away. So here we are, pressing like crazy on areas in the body that may actually have mechanisms that are altered. And so now you're creating, and you're a nociceptive trigger. You're a noxious stimuli, basically. You become a mechanical noxious stimuli by digging around with a needle or pressing around with your thumb or whatever other digging that you might do to set off this, what's the word called? Referral, to set off this referral, or to we go then to the whole pain treats pain idea of things. And what you may actually be doing is creating more problems for something that's already a problem.
And then people feel better eventually, and the therapist can then take credit for it, even though they may have prolonged.
Totally. Then they'll come back the next week and have a sore area again.
Yeah.
Because there's been this temporary change in something about the sort of nociceptive environment or some sort of downregulation, or I think it's called DNIC. I can never remember what all the.
Yeah, DNIC is, I think, the term that they used in animal studies, and conditioned pain, CPM, conditioned pain modulation, is what's used in human studies.
Yeah, which is super problematic.
Is that correct? Am I remembering those correct? Yeah.
I have read that in a paper recently. Yeah.
Yeah, I think I read that. We probably read the same paper.
Yeah.
And it's a
but
problem.
Some of those mechanisms might be there where there's something that happens when you press, and then there's some form of inhibition that occurs, and then someone feels better afterwards. We have a condition that keeps recurring.
Yeah. It's all
So,
fantastically interesting stuff, and it really challenges us to think differently about what it is we're doing and why it is we're doing it, and to give us a reality check on how good are we at treating pain. We tend to remember our successes and probably forget our failures,
yeah,
and we all have the best of intentions
we
helping
do.
people that hurt, and no one, and I think that sometimes when you talk about stuff and you challenge us, some people can be offended and say, hey, are you telling me what I'm doing is useless or I'm no good? And that's never even slightly what we're trying to get at.
No, and the big caveat here is that this is not necessarily our fault in terms of not having the pain knowledge. We understand this is a massive knowledge gap. And I think that actually, I understand it's a massive knowledge gap. You understand it. But I think that that is not well understood, is that we have this massive knowledge gap and we don't have the education we need to be able to necessarily fill that gap in a way that would make us reasonable in knowledge for mechanisms of management of pain. So when we're out here challenging the constructs, it's not because we're trying to tell people that they're wrong. It's because we want people to know that they're missing information and that we're starting to get much more of the information that they're missing. Now, of course, it does challenge the information that's been used to fill in the gaps and that people might be using on a daily basis.
What I'm excited for with this course, and I think it's going to be great. And actually, I know
I hope so.
I know it's going to be great. The having seen the content and having these conversations with you has been super inspiring and is really challenged me to make sure that I think I know what I know and also reflect on the stuff I don't know, and that's okay because we can't all know all the things, and that is.
Yeah.
I think that's an important piece of information that people are going to probably get from the course is that it's okay not to know everything. And we're here to try to fill those gaps. But this course is going to be 7 modules, 7 modules, plus there's going to be 2 support live webinars as well. So to help to fill that gap even more, because you're guaranteed you're going to go through this stuff, you're going to have questions.
Yeah.
And then,
for sure.
And then that's what those live meetings are for. There's going to be an asynchronous discussion community where people can post questions or comments. That's all going to be monitored by you. And I think it's going to be a safe, welcoming place for people to admit they don't know and to try to learn. And for us to say, that's a good question, we don't know either, but we'll try and figure that out for you. And we'll maybe reach out to other people that know more than us. But I think I don't want people to view this content or this course to be something that's elitist or something that's special. It's for the person who wants to know.
Yeah. So I'll reiterate the caveat again is that this information is not proprietary. I did not create this information. I simply put it together in a way that allowed me to explain it to myself and get a clearer picture of it. And hopefully we'll do the same thing for the people who are engaging with this, and to take that even further than I have gone with it. That will be the goal eventually, is that there will be much more information and education related to the foundations of pain science and the neuroscience knowledge that we're getting more and ultimately for the person in pain. But I'm not going to say it's challenging information. You and I have already been through probably fairly significant amounts of cognitive dissonance.
Huge.
And had to navigate that.
Yeah.
So we do understand when people are feeling challenged and or defensive with this information, because it's going to lead, for some people especially, it's going to lead to some cognitive dissonance. It's going to lead to discomfort in their thought processes.
Yeah. And that's what we're here. We'll be here to try to help you through that. Because to a lot of people, you hear this stuff and it seems a little maybe eggheady kind of academia stuff, and I don't understand what's that. What am I supposed to do with that information? I think that's a normal
Yeah.
initial reaction. But once you start to be able to integrate this stuff into your clinical reasoning and into making sense of what with your patients or clients, people that come to see you, whatever terminology
Yeah.
customers
Yeah.
you want to use, everyone uses different stuff. It really is helpful to help put some pieces together and
Yeah. And
provide
I think
treatments
that's,
that are, I don't think we could say more effective,
yeah.
but are more likely to not have negative effects, maybe,
Yeah. Yeah. And maybe less harmful.
and less harmful.
Yeah. For sure. Yeah. And I had a point and I've forgotten what that was, but no, completely lost it.
Any final
What,
thoughts?
what were you talking about just then? What were you saying just then? It'll remind me of what I was thinking about.
Oh, I was talking about the,
Oh, no, I got it. That's our challenge, right? Our challenge is to help bridge that gap between the knowledge that does seem out of reach and a way that we can bring it to people who aren't going to get to this sort of stage of putting together a course so they can understand the information. I've not just put this together, but I've reevaluated and I've updated it several times, and I continue to look at it on a daily basis. And people aren't going to do that. But we have to find a way to be able to, that's our challenge, to be able to say, look, we're taking this information. How can we make that understandable for you to simplify it without making it simple and without removing the nuance, but making it reasonable for you to be able to take it to a clinical setting and have a better understanding of what might be happening for your patient and where you may or may not be helpful.
I think that's a perfect way to end it.
Exactly. I want to end it.
I'm sure we could probably come up with some other things to talk about in the future, but this has been great, Monica. I've really enjoyed these 7 episodes, and I'm looking forward to going back and listening to them. I did the first couple, and they'll be coming out soon.
I don't know if I want to listen to it.
Don't listen, you can share them to your people. And
it's so hard to deal with how you sound to yourself when you're not used to listening to yourself.
it's a great thing about editing software is it makes everybody sound better.
Oh, what's that?
Yeah. I wish I'd used that early on in my teaching and podcasting careers, because it definitely, people listening to this, hopefully they'll notice that the last couple months of episodes sound much better than the first.
It's like a Zoom filter, but for your voice.
Yeah, exactly. So
that's great.
That's fantastic, Megan.
Yeah, and we'll be engaging more, and I'm looking forward to also to getting this going, and hopefully that we can have a really positive impact on our communities and on people who have pain.
That's the goal. I love it.
Yeah.
Thank you. Thank you for listening. I hope you enjoyed these series of episodes with Monica Noy. If you want to learn more about this topic, Pain Education, No Script Provided is a self-directed course which is now available for purchase on my website, thecebe.com. Please subscribe so you can be the first to listen to all my new upcoming episodes. And if you enjoyed this episode, please share it to your favorite social media platform. To connect with me, I can be reached through my website, or send me a DM through Instagram at Eric_Purvis_CEBE, or you can find me on Facebook at Eric Purvis RMT. If you'd like to financially support this podcast, please consider making a small donation. This can be done by clicking on the support button or heading over to buymeacoffee.com/helloob.